Now I welcome Dr. Md Salahuddin who will talk against the topic. Please, Dr. Md Salahuddin, come to the dais and give your talk.
Respected chairpersons, dear moderator, distinguished guests, dear participants, ladies and gentlemen, assalamu alaikum and very good morning. My topic, myself, Dr. Abu Zafor Md Salahuddin from Md Medical College Hospital, going to speak on immunosuppressants in unexplained GN where biopsy is not possible. I am against this topic. Glomerular disease affects individuals of all ages and it accounts for about 20 to 25% of the cases of chronic kidney disease. However, in children, teenagers and young adults, it is one of the most common cause of irreversible kidney damage and also a major socio-economic problem. The kidney biopsy is the gold standard for the diagnostic evaluation of glomerular disease. However, under some circumstances, treatment may proceed without a kidney biopsy confirmation of diagnosis. Treatment of glomerular diseases include non-pharmacological measures to control weight and blood pressure and the use of angiotensin blocking agents. For patients at high risk of adverse outcome, a variety of immunosuppressive agents are used like corticosteroids, alkylating agents, CNIs, mycophenolic acid, and more recently biological agents that act on B cells and complement pathway. We all know the indications of renal biopsy, and I am not going through details. And contraindications of renal biopsy includes some patient's factor, uncontrolled bleeding diathesis, uncontrolled blood pressure, uremia, obesity, uncooperative patients, and kidney perspective, active urinary infection. That includes acute pyelonephritis, perinephric abscess, and other some multiple cysts, solitary kidney, and malignancy. Renal biopsy cannot be performed in a low resource setting where desired investigation facility is not available and there is absence of skilled nephrologist and absence of nephropathologist. And some conditions where treatment may be considered without renal biopsy: antiphospholipid, anti-receptor antibody positive membranous nephropathy, some lupus nephritis in case where there is presentation like RPGN, uncassulated vasculitis, familial FSGS, anti-GBM disease, Alport syndrome, Fabry disease, and nephrotic syndrome in children under 12 years of age, and biopsy contraindicated as judged by the synthesis of history, physical examination, and laboratory testing. Is renal biopsy a necessary investigation? The role of renal biopsy has been much debated. Early studies suggested that renal biopsy provided diagnostic clarity in most patients, but this information did not alter the management, except for those with heavy proteinuria or systemic disease. More recent prospective studies have suggested that renal biopsy identifies a diagnosis different from that predicted on clinical grounds in 50 to 60% of patients and leads to a treatment changes in 20 to 50%. This is particularly apparent in patients with heavy proteinuria or AKI, more than 80% of whom have biopsy findings that altered their management. Is renal biopsy always necessary to start immunosuppressive therapy in lupus nephritis? This study was published in Indian Journal of Rheumatology, and in this study it was found that proliferative lupus nephritis can be predicted by serological profile alone, that is high rise of anti-dsDNA and reduction of complement C3 and C4. Thus, it might be argued that immunosuppressive therapy, that is steroids and mycophenolic mofetil, may be started without renal biopsy in a known SLE patient with laboratory evidence of lupus nephritis and positive serology. However, robust studies are required. The utility of renal biopsy in the clinical management of renal disease. There are currently no non-invasive investigations that are sufficiently sensitive and specific to provide accurate diagnosis in most types of renal disease. Renal biopsy is an essential procedure in the diagnosis of renal disease, and it is now hard to imagine that one could practice nephrology without knowing the pathology. Renal biopsy has been used to predict disease progression and response to therapy for the population in specific diseases like IgA nephropathy and uncassulated vasculitis, but others include lupus nephritis and FSGS. Immunosuppressive agents used in glomerulonephritis includes glucocorticoids, cyclophosphamide, mycophenolate mofetil or mycophenolic acid, or azathioprine, CNIs, mTOR inhibitors, B cell depleting agents, and plasmapheresis and low density lipoprotein apheresis. And some disadvantages of immunosuppressions include use of immunosuppressives is associated with development of serious side effects, reactivation of latent infection, gonadal toxicity, risk of teratogenicity in pregnant women, and maternal fetal complications and development of malignancy. Immunosuppressive agents with a narrow therapeutic index include CNIs, like cyclosporine and tacrolimus, as well as mTOR inhibitors, like sirolimus and everolimus. A little change in the dosing schedule may result in subnormal response or kidney toxicity. Therapeutic drug monitoring is crucial in these agents, which is costly and may reduce compliance. Glucocorticoids have both anti-inflammatory and immunosuppressive effects and have a long list of side effects, including infection, bone disease, including osteoporosis and avascular necrosis, hyperglycemia, obesity, hypertension, psychosis, GI bleeding, myopathy, cataracts, and suppression of HPA axis and long-term risk of cardiovascular disease. Other immunosuppressives like MMF and mycophenolic acid, cyclophosphamide, CNI, etc. are associated with serious infection, bone marrow suppression, hemorrhagic cystitis, gonadal toxicity, vomiting and diarrhea, hirsutism, gingival hyperplasia, hypertension, hyperglycemia, neurotoxicity, etc. And in a study by Jefferson et al., which was published in Clinical Journal of American Society of Nephrology, documented the adverse effect of selected randomized controlled trial of primary membranous nephrology. I am not going through details. And this is another one in patients with IgA nephropathy. Now, update on the treatment of glomerulonephritis in adults in low to middle income countries, which was published in European Medical Journal. A treatment approach that starts with diagnosis and proper use of adjuvant therapies mainly targeted blood pressure and proteinuria reduction is an effective therapeutic option and is recommended for patients in low middle income countries and with glomerulonephritis. The use of immunosuppressive therapies in adults with glomerular disease should, as far as is possible, be guided by the histological diagnosis obtained through renal biopsy. Due to the adverse effect of immunosuppression, prednisolone and cyclophosphamide use must be carefully weighted against the risk of potential side effects, and there is need for frequent monitoring of assay efficacy, patient response and adverse effect. It is not advisable to use immunosuppressives, that is CNI, that require monitoring of plasma levels in centers where such facilities are not available. And now the management of specific GN, IgA nephropathy. The primary focus of management should be optimized supportive care. IgA deposition with MCD, IgA with AKI, IgA nephropathy with RPGN-like presentation may require specific immediate treatment. KDIGO recommended that all patients with proteinuria of more than 0.5 gram per day, irrespective of whether they have hypertension, be treated with either an ACE inhibitor or ARB. Patients who remain at high risk of progression of CKD despite maximum supportive care of more than 3 or more months be considered for a 6-month therapy of glucocorticoids. In case of membranous nephropathy, kidney biopsy is not required to confirm the diagnosis of membranous nephropathy in patients with nephrotic syndrome with a positive APL-A2R antibody. All patients with primary membranous nephropathy and proteinuria should receive optimal supportive care. Immunosuppressive therapy is not required in secondary membranous nephropathy or in patients with membranous nephropathy which is in low risk, proteinuria less than 3.5 gram per day, serum albumin more than 30 gram per liter, and EGFR more than 60 ml per minute per 1.73 meter square, or a decrease of proteinuria more than 50% after 6 months of conservative treatment with ACE inhibitor or ARB. In terms of FSGS, immunosuppressive therapy should not be used in adults with FSGS of undetermined cause or in those with secondary FSGS. In case of PIGN, utility of glucocorticoids, the immunosuppressive, remain unproven and carry serious potential risk in bacterial infection-related GN, even in cases with crescentic glomerulonephritis. Specific antiviral therapy has been recommended by KDIGO for the treatment of hepatitis B virus, hepatitis C virus, and HIV infection-related GN. A decision for the use of glucocorticoids as an adjunctive therapy for HIV-associated nephropathy must be made on a case-by-case basis, as long-term risk of benefit are uncertain. Nephropathies due to infection with schistosomiasis, filariasis, and malaria be treated with appropriate antiparasitic agent in sufficient doses and duration. And in these cases, immunosuppressive agents are not used. And in case of MPGN, when the cause of immune complex-mediated glomerulonephritis is determined, the initial approach to treatment should focus on underlying pathological process. In patients with idiopathic immune complex mediated GN and proteinuria less than 3.5 gram per day, absence of nephrotic syndrome and a normal GFR, KDIGO suggests supportive therapy with RAS inhibition alone.
Doctor, you must keep your time in your mind. Okay?
Yes, sir. Yes, sir. Thank you, sir.
Sorry for intervention.
In conclusions, renal biopsy should be performed when indicated, and rational use of immunosuppressive agent is the mainstay of treatment of glomerulonephritis. Consideration should be given on adverse effects, effectiveness, availability, cost of the agent, and monitoring of drug level before selecting an immunosuppressive agent. And immunosuppressant should not be used irrationally in unexplained GN where biopsy is not possible. In most of the cases, when there is a non-nephrotic range proteinuria, we can treat those cases with supportive treatment with ACE inhibitor or ARB. And when there is a nephrotic range proteinuria or not responding to treatment, we may use immunosuppressive agents in a rational way. Thank you. Thank you all. Thank you for your patient sharing.
Thank you, Dr. Md Salahuddin.